Good afternoon, everyone, and welcome to our e-forum addressing anti-Asian racism in healthcare. CASLPO is pleased to provide this session today during Asian Heritage Month. A few preliminary comments before we get started. If it's possible, please close all other running applications to prove your connection on today's platform. If you are experiencing technical issues, we recommend that you exit and log back into the session, as this usually resolves connectivity issues. However, if that does not resolve your problems, please contact us at dei@caslpo.com, and we will try to provide you with assistance. The recording for today's session will be posted on CASLPO's website under About CASLPO in the Events section. The following presentation is intended for educational purposes only, and viewing this session can be counted towards CASLPO registrant's self-assessment tool learning goals. We have saved time today for question at the end of the presentation, and so we encourage you to enter your questions in the chat box that you should see on your control panel. Questions will be accepted throughout the presentation today, so please feel free to enter the questions and comments as they come up. We will try to answer as many questions live today as we can. And as a reminder, we are here today to learn, and so we ask that your questions be framed with an open mind and with respectful content. My final note is to indicate that some of the content in today's session may be triggering or may cause a significant emotional response. And so in those circumstances, we encourage you to take time for self-care when needed, and know that you can return to the recording after today's session and that staff are available for any follow-up questions that you may have. So with those matters covered, I am very excited to welcome today's speaker, Amy Go. Amy is the president of the Chinese-Canadian National Council for Social Justice, an organization that educates, engages, and advocates for social justice and equity for all in Canada. CCNCSJ, the acronym, has been at the forefront in terms of combating anti-Asian racism since January of 2020. Amy is a social worker by training and has dedicated her professional career to serving newcomers to Canada as well as seniors, promoting and advocating for cultural and linguistically appropriate care and healthcare equity for racialized communities. Over 3 decades, Amy has advocated for social justice and the rights of women and those within racialized communities through her various leadership roles. With that very short introduction, I turn it to you, Amy, to lead us through today's presentation.
Thank you so much, Priya, for the kind invitation and kind introduction. Truly honored to be here today. I want to first of all shout out to all the SLPs I've worked with, both at Yi Hong Center as well as other settings. Thank you for such dedicated services to the seniors and to the communities. Truly, truly an honor to be here today. Before actually I start, I would like to play a video which will set the context and set, I think, will leave an introduction to the topic today. Thank you, Bia, for playing that video. Thank you so much for playing that video. And in fact, as the video referred to, as the poet, social worker by training, Christopher Zeh referred to, we are on stolen land. So before I move on, I'd like to acknowledge that I, in Toronto, which is part of Treaty 13, signed with the Mississaugas of Credit, and truly grateful to be living and working in this traditional territory of many nations, including the Mississaugas of Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And it is now home to many diverse nations, Inuit and Métis people. I'm grateful to the indigenous communities that welcomed and embraced the abandoned Chinese railway workers into the communities after the completion of the railway in 1885. And as immigrant, I and we at CCNCSJ are committed to working with indigenous communities to achieve truth and reconciliation. So the topics that we are going to cover today would include the history of anti-Asian racism in Canada, yellow peril, the stereotypes of perpetual foreigner, the model minority, and in fact, the lived reality and the experiences of being Asian in Canada and the entrenched systemic racism that we are facing. And of course, the exacerbated hate that we experienced during the pandemic. And nothing new to us, health inequities that we are experiencing, and hopefully we'll end with a hopeful note that health providers, like all of us, do have a responsibility and can advance equity for all. So let's start with the history of anti-Chinese racism. Chinese came to Canada in 1850s to do the gold digging. And in fact, even during that time, it was very hard for Chinese laborers, workers to work in the gold mine because they're not white, and also or even set up their own ventures. So you know what? In fact, many of them worked with the indigenous communities in gold digging in the gold rush because they were also experiencing exclusion and discrimination. And in 1881, Canadian government need to bring our confederation to a fold by embracing BC on condition that a railway be built on through the most dangerous part, which is the Rockies. And in order to do so, the Canadian Pacific Railway imported 15,000 workers from China because what? They were cheaper. They were like, what, a third of the price of the white workers? And also because the white workers didn't want to do those dangerous jobs. It was said that each mile on that Pacific Railway, there was a Chinese worker buried on that railway. So after the completion, John A. Macdonald said that Chinese were just machines. It's time to return the machines. These were not human. These were disposable equipment. So in 1885, right away, he imposed a head tax of $50, kept going up to discourage Chinese from coming up till 1923. $500. $500, you could actually buy 2 houses in Toronto. Collectively, $23 million were paid by 85,000 Chinese. Not enough. Chinese kept coming. So the government imposed an exclusion act. It's called the Chinese Immigration Act in 1923, completely banned all Chinese from coming to Canada until 1947. Community groups, in fact, CCNC started seeking redress in 1985. We did not get redress and compensation till 2006 on June 22nd. Prime Minister Stephen Harper in the Parliament apologized in English and Cantonese to the Chinese taxpayers families, and the communities, and compensated accordingly. And let's look at the other communities in terms of the historical law. Salvation. We know Salvation communities is big and diaspora is very diverse. The first Salvation community started to come in 1903 from an area called Punjab in India. It's still, called Punjab. And of course, they didn't have voting rights. I forgot to mention that, in fact, Chinese, Japanese, the Punjabis, all did not have voting rights. In fact, there were many, many regulations, policies that were imposed municipally, provincially, federally, to ban and make life hard for Chinese and Japanese. For example, Chinese were not able to enter professions, Chinese could not vote, Chinese could not even hire white workers, Chinese could not marry white people. And there were certain roles in BC, you could not transport rice. So there were many other measures. And similarly, Salvation Punjabi communities experienced that hardship. And so, so Canadian government, they had to find a way to stop Salvations from coming. But it's different. India was part of British Empire. It was still a colony, and it was still run by the British government. We had the same king at the time. So what did we do? We had to be creative in barring them from coming. So the government said, if you came from India, India, Pakistan, that region, Sri Lanka, that region, you have to have this called one continuous ticketed journey, which means you could not stop anywhere in the middle. There's no way this long journey could, there's just no way that the people from India could come to Canada in those days in one continuous ticketed journey. In 1914, 376 of them tried to come in from the Punjab area, and on a boat called Komakakara Maru. They stopped through Hong Kong, and they tried to disembark in Vancouver. They couldn't because it wasn't a continuous ticketed journey. Stuck there for 2 months. Horrendous situation, no sanitation, no health care, poor, nutritional, no food, no nothing. Many actually died of diseases and starvation before they even got to turn back and went home. And after they went home, 20 of them were killed and they were imprisoned by British authorities, those who didn't die. So again, the Punjabi community here in particular fought for apology and finally got it in 2016 from Prime Minister Justin Trudeau. And again, we are not the only one. There was this Japanese Canadian community that we can also share with you today. You probably have heard of the internment. So Japanese came around the same time as Chinese in 1800s. Most of them were in farming and fishing industries. And by 1942, in fact, there were generations, at least 2 to 3 generations of Japanese. They didn't know Japanese, they only spoke English. But the same thing, they had no voting rights, they were barred from even teaching, they were barred from, just like Chinese, and excluded from many opportunities in life. And in 1942, Canada also practiced the same thing as other countries in the US, in even South America, in Europe. Japanese were then put in internment camp. And who paid for them? They themselves paid for them because the government seized and sold their properties, their homes, and everything to pay their own internment. 21,000 Japanese were interned. They were considered enemy aliens. And I said, many of them had no connections to Japan. And they were not released until, of course, after the war. And in fact, 1942, Japanese were even barred from the city of Toronto. Toronto said you could not even come in. And so after years of negotiating, lobbying finally in 1988, Japanese Canadian National Association of Japanese Canadian Council finally got their redress settlement from Prime Minister Mulroney. At the same time, because the Canadian government used actually War Measures Act to intern them. So they also successfully repealed the War Measures Act. And so after looking at the history, let's move on to the next topic of yellow peril. Japanese and Chinese were deemed as disease carriers, virus carriers. We were dirty way back when we first came. Chinatown in Victoria was grouped by the city of Victoria as the same as the sewage system. So now you can see how we were seen by the white Canadian communities, government. And so the yellow peril is not just a term to refer to us as being dirty. It was, in fact, referred to us as a threat to the white pure Aryan race, that our eccentricities, our immorality of Asiatic principles were just counter to all the Aryan principles and their, moral standards and all that. So we need to stop them. We had to curtail them. And that's the term yellow peril. And that's 1885. But of course, it's still very much alive and well and believed by many, including, of course, those who hold white supremacist ideology. Pat King, for example, he very famously and in his writings and through social media, he's told his follower there is an Anglo-Saxon replacement conspiracy. That means, these Chinese, Mandarin-speaking, or Hebrew and Jewish communities are going to take over Canada, and it's going to flood Canada with refugees. And when we were being hit and attacked during the pandemic, the attacker often said that we don't want your coronavirus. You carry this virus. You are the disease, the ground zero patients, for COVID-19 to Canada. So the term is very much still having an impact today. Let's look at other stereotypes that we are experiencing. Perpetual foreigners. I'm sure you can also identify with this one. Many of you can. So starting 1979, and well, first of all, we always seen as foreigners. That's why, Japanese were put in internment camp because you could never be Canadians. And that's why all that, that challenged our loyalty. And like Teresa Tam, Dr. Teresa Tam, Medical Chief Medical Officer of Health, a Canadian, was seen to be more loyal to the UN, to WHO, or the Communist Party, could never be trusted to lead our public health. And CDP, 1979, in their show called Campus Giveaway in W5, portraying Asian, particularly East Asian, many of them Chinese, as foreign students taking away seats from white students. In 2007, I saw the video myself at Queen's University School of Medicine in their recruitment video saying that, oh, don't go to U of T. U of T is too Asian. Come to Queen's. We are not too Asian. So too Asian means too foreign. 2010, Maclean Magazine, U of T, other university, too Asian. Meaning, being Asians, you're foreigners. You cannot be Canadian. Next slide. And this is not the only stereotypes that we encounter. We also encounter model minority myth. And some people will say, what's wrong with being called model minority? You study hard. You're scientists. You're SLPs. You're, even though they're not that many, but they're like, doctors and lawyers or engineers and accountants, So what's wrong with being, and you don't cause trouble, just like Chris was there. We keep our heads low. We don't cause trouble. We are not the troublemaker. What's wrong? let me share with you. I have told to my face in my 30 years career in management, in community agencies, in long-term care, told to my face by funder, by United Way years ago, by more recently, by a president of a foundation of a big corporation, saying the same thing. You Chinese are rich. You can easily raise $1 million. Why do you need to come to us? Meaning that we are wealthy, we can take care of our own. We are not entitled to get money from a public institutions like UT or from a publicly traded corporations that is supposed to fund community initiatives regardless of gender, race, ethnicity, and all that. You can do it on your own. This model minority myth definitely harm at the collective level, but also an individual level, where individuals, right, are not being seen as good artists. We are never good in drawing. We're never good in writing. We're never good in that kind of artistic expressions because you're better streamed to be, in science and other professions. And with these stereotypes, we also experience, and stemming from that perpetual foreigner myth, that stereotype, we experience microaggression. I'm sure many of you have experienced that. Where are you from? Where did you learn English? Again, it could be a small talk. My partner's a lawyer. He said, meeting small groups, most and all white, on Bay Street. The small talk, the sort of icebreaker is always turning to him, the only Asian in that room. Oh, where are you from? Again, assuming all the whites are from Toronto, my born and raised Torontonian partner was always the one being asked, and I'm sure you all have experienced that. Again, the implication behind that is you don't belong here. You are different. How come you're here? Next slide, please. Let's talk about our real reality, poverty rate. Some people think we're rich. We are definitely not. 15.3% of Chinese are below poverty line, according to 2021 census. 19% Korean Canadian. South Asian, 10.8%, but actually this data did not show the diaspora of South Asian. The Bangladeshi communities within the South Asian Canadians, actually communities has a very high poverty rate. And of course, Black Canadians, we know all live in poverty, have a huge number of us living in poverty. Look at the next slide, continue this reality. Chinese seniors, at $28,200 have the lowest income and highest poverty rate amongst all racialized and white groups. And this is again 2021 data according labor force. We have labor. We also have huge. We have higher than average unemployment rate, 6.2 for Chinese, 7.5 for Blacks, of course, South Asian and 5. Again, the diasporas of the South Asian community, and also Southeast Asian Canadian communities. Many of them are Chinese, ethnically Chinese, from Vietnam, from Cambodia, from Laos. Chinese, again, is a very diverse community. And the Southeast Asian community, again, have a higher poverty rate and higher unemployment rate. Next slide, please. And actually, there is a study done by University of Toronto and Toronto Metropolitan University that show that if you apply to a job and you use of course, my name is Amy Go, I would have 30% less chance to be called for an interview. And if I use my full name, Tang Tang Go, to apply for the job, I would have even less chance. And there's Asians now, in particular, actually Chinese, but there are, you could be Korean, Japanese, and South Asian, and Southeast Asian. your name alone would prevent you from advancing, from even getting a job interview. If you don't call it systemic racism, I don't know what else and how else you would name it. Next slide, please. The pandemic. We all know how bad it is. So I'm not going to great detail because I'm sure many of us, many of you have known families and friends. My sister, she's now a judge. She was a lawyer at the time, walking on the street, Young Street, going to work, spat on by a group of 4 white youth. They ran away, smiling, yeah, and laughing at her. My brother, senior, walking with a cane near his house, got something thrown right in front of him. Good thing didn't land on him, did not hit him. So Chinese Canadian National Council Toronto chapter, Vancouver, Asian Film Festival, and Project 1907 came together, and they invited community members to report hate incidents. Just in the year 2021 compared to 2022, 2020, 47%, and that's consistent with all the other data that we're showing, that we're seeing from police services, from surveys, and all that. And the target specifically, women, seniors, and young people, young children being targeted. So if you move on to the next slide, that would show you it's done. This is collected by census, StatsCan, that the perceived frequency of harassment and attacks, Black, Korean, Chinese, Filipino, West Asian, many of the West Asians are from Muslim communities. And so, the intersectional lens of religion and race definitely into play here. And we know how Islamophobia played a critical role in the vicious attack against the Muslim family in London, Ontario. It was just horrendous. Arab, South Asian, Southeast Asian, all the communities that I mentioned have experienced high number of harassment and attacks based on just who they are. Next slide, please. So if the pandemic not only exacerbates, the hate crimes, but it also exacerbates disparities and inequities. I'm speaking to healthcare providers here. Let's look at vaccination rates and higher infection rates. And we all know that during the pandemic, the vaccination rates was so low in certain communities that the public health, City of Toronto Public Health, community groups, community healthcare centers have to work together, dedicated efforts to go to those communities so that they can raise the vaccination rates, so that they can, as much as possible, prevent the spread of COVID-19 amongst those already poor communities. And these racialized communities also are the ones that work in the front line. They continue to provide us with food. They are in the food factories. They are the delivery people. They are the restaurant workers. They are at the front line. And they had no rest. While some of us could stay at home, do virtual meetings, but they had no choice. So their exposure is high. At the same time, they are not protected from the vaccine. So that disparity is so clearly demonstrated during the pandemic. And if you look at the next slide, the infection rates, you can see compared to white, Latino, South Asian, Middle Eastern, again, the West African, many of them are Muslim, Southeast Asian, which I mentioned, Black and East Asian. Chinese and East and Japanese Canadians have a lower infection rate, which is also interesting because actually I live very close to Chinatown. In fact, Chinatown has very low vaccination rate because many of the residents here in Chinatown work in the front line are also migrant workers, probably have no insurance, also are undocumented. They actually are afraid to come out to get vaccinated because they don't have OHIP card. They're afraid that the authority will catch them and send them back to where they're from. So, however, of course, there's also a high in vaccination rates amongst the middle class, Chinese Canadians and other communities. Can we turn to the next slide, please? So the experiences of being in the front line as healthcare professional during the pandemic. This is direct quote. I had the opportunities and privilege to speak to many healthcare professionals, seniors, parents, young children during the pandemic for various projects that CCNCSJ was engaged in, as well as for our own educational resource development. The healthcare professional told us, yes, they were serving patients who are infected by COVID-19. They saw this Chinese face and say, you go back to China. You brought this to me. You brought this to Canada. And then many of the healthcare professionals said, in fact, the experience, the discrimination, the misogyny, the racism that we experience is not new. The pandemic merely exacerbates that. We have experienced that all our career. And many of them actually have experienced that when they were growing up in Toronto or in small town Ontario or other parts of the country. It was a tremendously challenging and difficult conversation to hear and heart-wrenching to hear the Asian Canadian professionals providing care to the communities and also had to deal with their own emotional toll during the pandemic, sharing the racism and the attacks that they are experiencing. Here, this is a direct, experience shared by a manager in a healthcare institution, a woman, Asian Canadian woman, saying that she attend, whenever she's going to a meeting, and usually, of course, white people, the assumption would be made that, oh, the only Asian face, only Asian woman, you must be the secretary. You must be the one taking note. I'm not suggesting that there is any shame or anything less being a secretary. But the assumptions made by the others is you're here to serve me. and also, at SLP, saying that she was going to clients' home, and the clients immediately, oh, you remind me of that. Again, not to suggest anything wrong, anything less being a nanny, but the assumption, the connection, what I'm saying is that stereotypes of the Asian, the Canadian women in particular, are here to serve me, here, and also we all look the same to them. We all are faces in a way. We are just merely a part of a group that is all the same to many of these white people. Next one, please. And if you look at our healthcare system, so as we know, and in fact, recently I went to Queen's Park for a conversation about access to primary care, because Chinese-speaking communities are experiencing huge problem in getting primary care. In particular, they don't have the language and culturally responsive care that they can get. Many of the Chinese-speaking medical practitioners are retiring, so it's a huge issue now. And the primary care, I mean, we all know how bad our primary care system is and how bad our primary care system is to begin with in responding to communities that don't speak English, but in particular, Asian Canadian communities, the diaspora of Asian Canadian communities, the Tamil speaking, the Urdu speaking, the Gujarati seniors, the Ismaili seniors, the Chinese speaking, the Korean speaking, where do they get care? The barriers are so deep and so wide. And how are needs being identified? And when are referrals being made? I like to ask to you and SLP, I'm sure you all get referrals. How do the providers who may not understand the language, let's say of a 2-year-old from a family of immigrant who speaks Cantonese or Urdu or Gujarati or Korean, how do the professional, identify their linguistic development and their needs? If they don't make the effort to understand, and if they don't break down that barrier to understand in order to make that proper referral for assessment, or would that means that, oh, this because they speak Chinese, their English may have a different development in terms of accent and all that. Does it also mean, oh, that means there is deficiency, that we need referral? Is that an issue of over referral, under referral? I would guess actually under referral, but because I, as a healthcare provider, I also understand how advocates work. If you have family members who speak the language, who really fight for your rights, you do tend to get better access. When the immigrant families who don't speak the language, who are economically challenged to begin with, can't really accompany and be there when the assessment was being done, it is very hard for them to advocate for referral. So, and how culturally responsive is the care? The standard assessment tools, how are they really truly standard in meeting the needs of the various communities? Next slide, please. I would try to speed up. So my years in long-term care and in community care, I've learned great lessons in health inequities and really come to appreciate systemic racism, discrimination, the whole superiority, privilege, and power. I would just use one example to illustrate to you what I mean. When I was at Yihong Center, a senior in Markham had to be sent to the hospital because of an acute change. This senior actually had years of depression. Came to Yihong, we developed the rapport, we managed to develop the trust of the senior, and he was stable, he was calm, respectful, tend to be quiet and not very demanding because of his, depression. So he was sent to the hospital for assessment, for treatment, and he only spoke Cantonese. And what happened was in the hospital, and then this senior was competent. He could take care of himself. And he wanted to go to the washroom. Because in the hospital, you're in a strange environment, you didn't know where the washrooms are, you were, and all that. So he asked for help. And he spoke, of course, only Cantonese. No staff bothered to understand what he was trying to get or need. And so he got frustrated. He had dignity. He did not want to have an accident. He got frustrated, he yelled. And instead of, again, trying to understand him, they put him on restraint. They called him belligerent. They called him aggressive. The senior came back. We didn't know. Of course, it's not, this is, the hospital wouldn't tell us this episode. We noticed the senior was very upset, very depressed. In fact, he was in tears when our social worker talked to him. He recalled this and then he said, I would never, ever, ever go back to an acute care institution. The whole issue could have been resolved by the hospital taking care, trying to understand his needs. But instead, safety We always use the term safety, wouldn't we, in healthcare? The seniors seem belligerent, aggressive. We applied the extreme measures to put restraint because he is no longer deemed safe to himself or to the others or to the staff. I challenge all of you. When we define safety, whose safety are we talking about? Whose safety are we really trying to uphold and protect? Is it the patient's safety or is it your own convenience? So please, please have consideration this whole concept of safety. And when we apply standard assessment and we say excellent in care, appropriate care, what do we mean? In Yihong, we actually had to modify the mini mental test in order to make it more culturally appropriate. Many of the Chinese seniors actually did not have education. The ones that I worked with in my last 30 years, now, things have changed. But in those days, many of them did not have the opportunity to have education. And this is true for Korean seniors. This is also true for Southeast Asian seniors, and also true for South Asian seniors, because I had the privilege to work with all of them. So we had to make those assessments more appropriate. And the mini mental test, for example, name 3 objects. Of course, you're not going to use hockey stick as one of them. So when you do assessment tests, when you refer to objects, when you do you consider the cultural nuances? Do you consider the biases inherent in that? And are we over-referring, under-referring, as I said earlier? And do we really look at evidence-informed care? And whose evidence are we gathering? So that leads me to the last slide about health equity. It is so important for us to look at evidence-informed practices from a disaggregated health equity data perspective. We need to collect data that would include the race, gender, language, culture, religious practices of the communities that we serve. Then we can examine the impact of our intervention on them, the outcomes that may be differentially experienced by them. We are only at the beginning. There is a recent report that came out. Seniors, the diasporas, the seniors from various particular racialized communities are experiencing services differently, outcomes differently. But in Canada, we don't have a systemic system to collect data, to review, to research and all that. I plead to all of you as healthcare providers, please gather evidence-informed data and work with the communities to gather. This data is mine. This data is mine as a patient. This data belongs to the communities. We all need to play so that the data interpretation will not further harming us, but really used to advance equity. I want to applaud the College of Audiologists and SLPs Ontario for your guidelines on equity and inclusion services. You already have a lot of good principles, engage in anti-racist, anti-discriminatory practices, applying the anti-colonial lens, applying those lenses to your practice. And you also highlight practice with cultural competence and cultural humility. And I cannot say enough about the importance of humility, because we have been collectively harmed by a system that has this sense of superiority, that has this sense of being better than the other communities, than the other systems. And it has really, truly harmed us, the racialized communities. And you also have the principle to address and recognize conscious and unconscious biases. It is so important for us, all of us, to keep all that in mind when we are practicing, so that we can collectively change the system. That concludes my presentation. Thank you.
Okay, perfect. Thank you so much, Amy, for that. I think the experiences that you shared are incredibly and particularly powerful, and I think it supports our educational endeavors as well as our commitment towards allyship. So there are a couple questions that we have for you, and those who are in attendance, feel free to enter any questions that come up as we have the continued discussion. Bia, if you could go to slide 8 for me. There was a photo of a woman holding a baby. It appeared in that slide. Could you, Amy, walk us through what these tags are, the implications around that?
Yeah. So they were all numbered, right? This is a mother with a daughter going into internment camp. They were basically just number. And in fact, I don't know if you remember the Star Trek who plays Sulu, George Sakai. He remembered his number. He was a child in internment camp. And he's not the only one. He was in the American camp, in the Canadian camp. They were all just assigned a number. And this is so and true like illustration of the racist system, right? You are no longer a human. You are merely a number. You are merely an object for me to transport, to ship, and contain, and basically locked up, during this period. And that is consistent with that theme, right? Of being like your face, your personal identity doesn't matter. You're all Asians, you're the same, you're all like, just this blend, collective, and this group thing. And this is so like, thank you for asking that question, Priya. It's exactly what we are experiencing when we are called each time, where you're from, that our name, became a barrier for us. The way that we walk, the way that we talk, sort of it is seen as being from the outside, a foreigner and all that.
There's, I think, an incredibly dehumanizing effect when you are categorized, and your identity, your personality, everything that you are is stripped down to a number, and that obviously has significant psychological and emotional effects on the person, but obviously, I think as you've taken us through, has broader ramifications for how society treats people. I have another question, and I think it's a little bit of guidance, perhaps, from one of, I think, our practitioners. And the question is, how do you address microaggression when you are providing care to a patient? Unfortunately, this has happened to the person, and so they're looking for strategies on how that can be managed.
I know. It is really challenging. I understand and appreciate. First of all, I really hope that all organizations would support their own staff, right? Whether you belong to it's called health and community, like you are contracted by the agency, or you're part of a healthcare institution, or whatever institution that your employer is. I would urge the employer to have a process in place so that their staff know what to do, and also have the chance to follow up, to be supported, to also have a system to address those microaggressions, to address those in speaking to your clients and speaking to your patients, and understanding, of course, that we need to be sensitive, and we need all that, and respectful and all that. But aggression is aggression. Microaggression, like if we talk about safety, it is a safety issue. It is the well-being of the care provider that we also need to uphold. So I would put the onus on the employer. And of course, I would urge you not be shy, from pointing that out in a gentle and respectful way. And then, of course, seek support and seek counseling for the experience that you have gone through. Sharing, learning from each other always helps. Talking about it, and building allyship always helps. So I think there are many things that we can do to develop. And many organizations now, when they engage client, there is like a contract of like, respect, right? And it is so important for us to point that out to the client, that when you're receiving our services, we expect certain behavior and from you. It is part of that agreement, part of that contract.
I think that that's incredibly helpful, and it's very true. I think we all share a responsibility in managing those. It's not just a one-on-one interaction, and unfortunately, sometimes using those terrible experiences is some of the best ways and information to provide better change. And I just want to stress the importance of self-care as well in those circumstances.
Yes.
I think there is a highly damaging effect of years of microaggression that, if not managed and addressed, can definitely have significant impacts on the person. So turning to another question, and bear with me as I go through it, how can practitioners help patients who believe in non-Western medicine and therapies? How can they feel more comfortable in a Western clinical setting? So bridging the patient between perhaps cultural or historical or even family beliefs.
I know this is an experience that I've had for years at Yihong, right? I'm working with Chinese and Indian residents and Tamil residents. They all come with their traditional healthcare practices and beliefs. And it is, first of all, we need to recognize that, right? We need to accept that sense of humility. We learn, first of all, right? You do not undermine, you do not make fun, you do not show any disrespect for people's beliefs and practices. That's the first criteria. Second is that we also do not show our biases, right? That Western way of doing things is always the best. And yes, we are trained in the discipline. We are trained in this professional skills and all that. However, we cannot show any disrespect to others. So that's the most important. Second of all, I think to learn. So asking, like, okay, here I am sharing with you my profession has taught me this skill set, right? Has taught me this is the way we handle it. This is the way that we address this, we approach this, we treat this, and all that. Explaining that and the reasons behind. And ask them, is there any of that, that you have questions with? And how would you, in your traditional way, what is the difference? Why would that make it challenging, difficult for you? You really have to understand why would that be an issue for them to not necessarily be, I would say not compliant, but to not necessarily show an understanding or embracing that treatment, right? Regardless of what it is. So I think it is that conversation, that understanding, and bringing the two. And sometimes I believe bringing the two, having that conversation really, really helps. And for us in Yihong, one of the key things that we learn, pain medication. Our residents don't take pain medication because the Chinese believe that it will hurt your stomach, it would be devastating to your system. So they would put up with like great pain and not take pain medication, So we really have to address what are their worries, what's their anxiety, what is that, can we sort of meet middle ground? Can we, with their practices and with this treatment, how can we? It is so important to understand where it comes from, why that anxiety, why is that lack of embracing.
That's excellent. I think it leads me nicely into The next question, in terms of where our participants and our viewers can find more information on supporting the South Asian community, and in particular, supporting children who may be dealing with these types of microaggressions or outright discrimination, how they can be supported, especially for our audiologists and speech language pathologists who are working with children in the school board setting.
Yes, exactly. So actually, if you go to our website, Chinese Canadian National Council Social Justice, if you don't mind putting it in the chat line, CCSG, ccncsj.ca, I think. No, but because we actually have resources specifically dedicated to straight conversations with young children about racism. We actually developed those resources together with the educators in the system. So they are very familiar, and you see videos of young children having conversation, and in fact, those come from them. Many of the videos came from the children themselves, even though you see that those videos are focusing on East Asian and Southeast Asian communities, but I believe they are applicable, or at least you can have an idea, right? And also adapt that for the communities appropriately. And also, the Toronto School Board actually has a resource on anti-Asian racism. And that curriculum developed, in fact, with a lot of the same educators that we work with. And they actually also looked at our resources before they completed them. So if you go to TDSB, they also have anti-Asian racism resources targeting children. And there is another organization that I work closely with, the Council of Agencies Serving South Asians. They have tremendous resources on racism, Islamophobia, and all that. They may not be specific to children. I believe they might even have. They are like tremendous resource that I would urge you to go and look at them and reach out if you need more.
Perfect. That's excellent. And we will circulate links to those organizations when we advise the posting of today's session. So I am cognizant of time, so I'm going to close out today. Amy, I want to thank you again for such an amazing and really insightful discussion. I think, personally, I've learned a lot, and I hope that it's helped even in the smallest ways for some of our participants in their care and delivery of services for people in Ontario. As we mentioned earlier, today's session will be recorded and posted on CASLPO's website, where you can also find recordings of our first and second sessions in this series addressing anti-Semitism in healthcare, as well as addressing Islamophobia in healthcare. On June 11th, please join us for our next session in this series addressing 2S LGBTQAI+ hate and transphobia in healthcare. And if you have not already signed up for this session, please note that there will be 3 questions in advance to give our speaker an idea of the issues and concerns that you have. I want to thank everyone for joining today, and I hope you have a wonderful, sunshiny afternoon. Thank you.
Thank you. Thank you so much. Appreciate it.
Bye.
Bye-bye.